I was definitely gay when I was a little boy. A lot of little boys are gay, you know? They're very flowy and they have hard opinions on things.
Greetings, friends. Given it's now winter, and as you may, or probably at this point maybe not, can tell from a little bit of a crackle in my voice, that means it's also flu season. Yes, that marvelous time of year where everyone and their mother has the sniffles and coughs. But what about you, dear friend? Do you? Do you have any symptoms of the flu, or even more run-of-the-mill, like, disorders that might generally be labeled as under the weather? Yes? No? Well, today I'm going to be your doctor and diagnose you, because it just so happens that even if you don't know you are suffering from a certain disease, you may in fact be suffering from a certain disease. Being asymptomatic does not mean you are not suffering. Because, screw the flu, there is a far more important diagnosis that we may need to make about your current physical and psychological condition. You, dear viewer, may in fact be suffering, or may soon to be affected, by a widespread new disorder that has been running rampant across the global landscape, and yes, you yourself may not even be aware that you are experiencing it. What is it? Is it the lithium in the water turning the frogs sane?
Look at me, I'm a gay frog. I'm so cool, I'm so neat. I'll never have children and I'm sterilized.
No, we covered that. Is it Ebola? Because that's exploding almost as much as all the grenades in the Congo right now? No, forget that. Who cares about that?
Every shady little village in Africa has Ebola.
Is it the Black Plague, which has made a major comeback and is being literally raised from the dead via the people of Madagascar, bringing the disease back into vogue by dancing with deceased bodies, and therefore is likely to become antibiotic resistant in its new modern environment? No, forget that too. That doesn't matter. This is a far more important diagnosis than any of that other dumb crap that nobody in the world cares about. What I'm talking about today is rapid onset gender dysphoria, a far more pressing matter for those of us here in current year +3 or almost, is it 4, 5, whatever, in the first world. This is what really matters. Particularly because, as I mentioned, you yourself could be at risk and not even know it. You may in fact actually be suffering from it right now and not even be aware. Are you a woman who doesn't usually wear dresses? That could be rapid onset gender dysphoria. After all, a designated female at birth as young as 9 in Wales was recently diagnosed with gender dysphoria and given hormone blockers because he didn't like to wear dresses. Similarly, are you a young man who likes wearing kilts? Well, that could be rapid onset gender dysphoria. Actually no, wearing a kilt's pretty manly, never mind.
You want me walking around in long white hockey socks with my balls hanging out, with a multicoloured skirt and a cock back? It's still girly. It's still girly to have a bag. I don't care. We've done our absolute utmost to address the situation, and it's gonna be hairy.
Anyway, despite transgender people comprising currently less than 1% of the total United States population, a surprise if you were to pay any attention to the mainstream media coverage of anything and everything having to do with transgenderism, yes, gender dysphoria is on the rise and continues to be a condition linked to high suicide rates, something that we're told continually is a major concern for public health, and it is. No one should kill themselves. If we have a large portion of the population doing this, there should be something we can do to cure it or at least mitigate it, right? That's why early prevention and diagnosis is key. So today, dear friends, to help solve this public health crisis, I'm going to go through some recent research to help you determine if you, or someone you know, is either likely to soon experience rapid onset gender dysphoria, or is actually currently experiencing it and just hasn't been properly oriented, I mean informed about it. Actually, am I even allowed to call this a disorder, or a disease, or an epidemic? Is that transphobe? Let's continue. In August of 2018, Dr. Lisa Littman published a study on PLOS ONE on the topic of rapid onset gender dysphoria, something that had kind of been discussed in some circles before, but which there really wasn't any empirical data discussing. And it was a study that was initially also reported on by Brown University, where Dr. Littman is a faculty member. So what is ROGD? Well, it describes when post-pubescent people suddenly and out of the blue seemingly recognize they do not identify internally with their biological natal sex. And when I say natal sex, that's the term I'm going to be using for the rest of this video, that means assigned at birth. But often we hear about gender dysphoria and becoming transgender as a lifelong process, something that people have expressed since very early childhood, yet here we have some evidence that shows that it can be rapid onset post-pubescently. That means all of us, including you, dear viewer, and I'm sure my videos are age restricted, so you better be over the age of 18, are vulnerable to this disorder or disease. Again, am I allowed to say that? But anyway, as with any other medical issue, some people may be more susceptible or prone to developing this rapid onset disorder than others. Although we still only have some very preliminary data, what we do have from Dr. Littman's study is a lot of correlational data that can help to determine people who might be at greater or lesser risk for developing rapid onset gender dysphoria. Based on data that she collected from 256 parents of adolescents who had reported becoming transgender after puberty, we can identify then some of these factors. So listen and follow along in your book as we go through the various traits that make you, dear viewer, potentially more susceptible to a sudden desire to become another gender, which may be particularly confusing as we know there are so many.
So, I'm actually, fluid binary, meaning that depending on the moment, I kind of go between different genders.
Interesting.
So, today, I'm astral gender right now, which is I'm a gender from outer space.
As two hosts who couldn't find a door yesterday to get...
According to Dr. Littman's research on young people who did develop this thing she called rapid onset gender dysphoria, you may be more in danger if any of the following traits describe you. Having expressed any sexual interest in people of the same sex, at a level of 41% of her participants. Having any of the following mental health disorders or issues. Depression at the level of 39.4%. ADHD at 11.6%. Obsessive compulsive disorder at 8.4%, autism spectrum disorder at 8%, eating disorders at 4.8%, bipolar disorder at 3.2%, psychosis at 2.4%, or any other mental health issue reporting at 2% of her respondents. Having experienced any significant stress or trauma comprising 48% of respondents, particularly when it related to family-related stress at 44% or sexual stress or trauma at 30%. Have you struggled coping with negative emotions? That was related with 58% of respondents. Have you felt overwhelmed by emotions? That was 61.4% of respondents. As a child, experienced any of the following problems. Social anxiety, 69.4%. Had problems associating with peers, 44.3%. Were socially isolated, 43%. Felt excluded socially, 36.5%. Or were bullied at 29%. And while this was a study aimed mostly at adolescents, some of you may still fall into this category. 88% of participants in Littman's research who reported rapid onset gender dysphoria lived at home with their parents. So be wary when you're living at home with mommy and daddy that your good boy points could soon turn into good girl points. And specifically of interest to us today, being biologically female seemed to be heavily related to developing rapid onset gender dysphoria, with 83% of Littman's participants being natal females. But if a lot of what I just stated sounds like it could describe any person, let alone any average young person, or even any average woman, having one or more of any of those individual characteristics, including you, dear viewer, don't worry and don't jump to conclusions just yet. Let's look at some more variables that seemingly define and typify the victims of this rapid onset gender dysphoria. According to this specific research, it has nothing to do with child manifestations of gender dysphoria, nor nonconformity on a clinical level, with 2 or more criteria of gender dysphoria typically being necessary for a diagnosis in childhood. And with none of the parents interviewed and surveyed in this research reporting 2 or more symptoms of gender dysphoria during prepubescence. That means that even if you have never experienced any manifestation of gender dysphoria, either as a child or as an adolescent or even as an adult, you can still develop this rapid onset gender dysphoria. 95% of parents in this study reported 0 indicators of gender non-conforming behavior in their children before puberty. That means yes, you too, all of us, in fact, could be at risk. According to these parents, 32.4% of children who reported feeling dysphoria and desiring transition displayed no previous indications of dysphoria before testing. Additionally, 26% of children developed symptoms within a month. So what else defines this rapid onset gender dysphoria? Let's investigate it a bit further. According to these data, other potential explanatory variables, or at least correlates as we have so far in the initial research, include being friends with others who recently, quote, came out as transgender, 21.5% of Littman's sample. Increased social media use, 20%, or both at the level of 45.3%, with a total social influence factor within this dataset comprising 86.7% of participants. So, using social media and being friends with someone who recently came out. Having transgender friends, the average was 3.5 transgender friends. So, I suppose if you want to avoid this, avoid the trannies, Oh god, that was insensitive now, wasn't it? Can we cut that? But particularly, it was important in what order people came out. Of the children that developed this rapid onset gender dysphoria, only 3.4% were the first among their friend or social group to come out as transgender. 43.7% were the second among their friend group, 27.7% were the third, 15.1% were the fourth, and so on with the additional 10.4% of respondents. It seems all it takes is one simple friend.
How's the patient, doctor?
He's gonna make it.
You came in with a sheet.
One little mistake.
So how does this manifest? We often hear about the difficulties faced by transgender people, particularly transgender teens, when they decide to come out to their friends and family. But that's not necessarily what Littman seemed to find in her data. 60.7% of parents reported that coming out actually increased the popularity in school of their children, with some parents noting that it protected them from bullying. That seemed at odds with everything we've ever heard about coming out as trans or gay, right? It actually made you more popular? Well, considering that a similar 60% of parents, when they also reported being aware of the behavior, generally speaking, of their child's friend group, that said friend group was known to publicly mock or bully students who were not transgender or LGBTQ. In expanded responses, one parent said, "They are constantly putting down straight, white people for being privileged, dumb, and boring." Another participant elaborated, quote, "In general, cisgendered people are considered evil and unsupportive, regardless of their actual views on the topic. To be heterosexual, comfortable with the gender you were assigned at birth, and non-minority places you in the most evil of categories within this group of friends. Statements of opinions by the evil cisgendered population are considered phobic and discriminatory, and are generally discounted as unenlightened. You worthless plebeians." You know, it really wallops my walnuts. I can't imagine why it would be then that for these students, their popularity at school would increase, not only when they were being protected by teachers who are heavily against transgender bullying, but also when the other kids that they associate with are children who behave in that kind of way. I mean, with friends like that, who needs fertility, healthy breast tissue, or a non-inverted penis? Luckily, these young people don't just have allies at school, they have plenty of other allies online, and since this video is a 100% accurate diagnostic tool to determine whether or not you, or someone you may know, has rapid onset gender dysphoria or may be soon to develop it, let's then look at the correlations between internet use and social media use with young adults who began displaying symptoms of ROGD, just so you know where to avoid. Looking up information and asking about transitioning and being transgender on the internet. That was 54% of participants. Being told online that you should transition immediately without deliberation found in 34.7% of participants. And further, that you will regret it if you wait and deliberate in 29.1%. Being told that if your parents disagree with hormone therapy, or maybe not your parents, insert your own social group, friends or family there, I suppose, but if they disagree with you taking hormones or transitioning, that those people are transphobic and bigoted, 34.3%. Received advice on how to talk to a doctor to convince him or her into prescribing hormone blockers or hormone therapy to you, 22.3%. And further, receiving information that it is okay to lie to medical professionals in order to attain that goal in 17.5% of respondents. if people in your life disagree with you undergoing hormone therapy, that you should threaten suicide or cite transgender suicide statistics to them. 20.7% of respondents. Yeah, if you've come across any of those things, seems like you may typify someone with ROGD. Particularly though, we should look at the sources of some of these information. So if you, viewer, are trying to find out if you too are soon to identify as transgender, or are, like a disgusting bigot, trying to avoid outlets that might place you at higher risk as I've described, parents did note the following sources or environments being used by their children shortly before and after or during the onset of their gender dysphoria. YouTube transition videos, 63.6%. Tumblr, 61.7%. Well, hopefully not anymore. A group of friends that they knew in person, 44.5%. A community or group of people that they met online, 42.9%. Or a person they knew offline, 41.7%. Of the survey of over 200 parents, only 2 reported that they believed the source of their child's rapid decision to become or identify as transgender was unrelated to external mediating or influencing factors. So, now that we have a pretty good idea of who is at greater or lesser risk of developing ROGD and under what circumstances, we can start to get into what is ROGD, what is gender dysphoria, why does it matter, and what the heck does all of this mean for society, and more importantly, for you. Considering you may be at risk. Did you cross off any of those boxes I mentioned? Well, be prepared to start cross-dressing literally tomorrow. Except probably not.
Fucking hell, look at these guys. They got a ton of makeup on, Jesus. Okay, hey Steve, have a look at this. Gee, my God, they got guns as well. It's the National Rifle Association Transvestite Wing.
Based on what we've seen though, currently, being the natal female sex, having some sort of neurodivergence or mental health issue, having a friend group that includes at least one other transgender person, being exacerbated by the more people that there are within your friend group who are transgender, particularly when that friend group mocks, dislikes, or bullies cisgendered people, and using online platforms to learn more about being transgender, transitioning, and just talking about whether or not you are trans, are all risk factors. And while there's some things you could do to quarantine yourself from these factors, such as cutting out people from your life who mock and bully others for their gender or sexual identity, and avoiding using Tumblr, which, really just good advice for everybody on both counts, there are some other things, like having autism or ADHD, that are just going to place you at kind of a higher risk when we talk about correlates. In addition to being female, at least currently, and although I guess you could stop being female, that kind of puts us into a weird cycle, right? But this all kind of brings up an important point. Why should any of us even be concerned with ROGD? After all, it seems that coming out as trans can increase your popularity at school, contrary to what we often hear in the media. So Aiden, what are some of the symptoms of this newly identified aspect of gender dysphoria? Well, according to the Littman study, parents reported the following. Worsened mental health or well-being in 47.2% of respondents. Worsened parent-child relationships, 57.3%. Unchanged or mixed academic performance, 59.1%. And narrowed range of interest and hobbies, 58.1%. At least your grades don't suffer, right? It seems that there are problems with one's mental and social states that present after coming out as gender dysphoric, and the mental health issues make sense as gender dysphoria itself is considered a mental health disorder by the American Psychological Association in the current version of the Diagnostics and Statistics Manual. Of course, there is also the big problem that I mentioned earlier. The big problem in the room when it comes to transgender people and gender dysphoria, that being high rates of suicide, suicidal ideation, and self-harm across those who identify as transgender or gender non-conforming. As we can see here in Haas, Roger, and Herman 2014, who identified among several other variables that affected or were comorbid with being transgender, the researchers found that 46% of trans men and 42% of trans women had attempted suicide at one point. They also found that transgender and gender non-conforming people tended to have relatively lower income than the United States average, being between $50,000 and $60,000 a year, but with 59% of people who are trans or gender non-conforming making less than $50,000 a year annually, and with a full 15% earning less than $10,000 a year. There are also potential issues there for educational achievement, as transgender people may have a slightly below average college completion rate, with the Haas data indicating a 27% of their sample having completed an undergraduate degree, in comparison to the average United States having about a 32.5% completion rate. Albeit, I am comparing a data set only concerning individuals over 25, and in the Haas data, 19% of their respondents were 24 and under. And it's also worth noting that among the transgender population, there was a much higher completion rate of advanced degrees in comparison to the general population at 20% versus the general 12%. But this kind of relates to something that Littman noted in her report, that after coming out as trans, 12% of her parents reported their children dropping out of high school, college, or becoming unable to maintain a job around the same time as becoming transgender or identifying as gender dysphoric. And in those cases, the 30 that were reported, 43% of those children had previously been identified as academically gifted. This aligns with the fact that 30% of this population reported being unemployed, indicating a withdrawal from social activities, further indicated in Dr. Littman's sample of parents and trans children, who reported 49.4% of their children tried to isolate themselves from their family, 32.2% lost interest in activities unrelated to the LGBTQIAA community, 32.3% stopped spending time with friends who were not transgender, and 22.7% began to become distrustful of non-trans people in general. Moreover, there may be some pretty significant implications for physical health as well as mental health, as Ryder et al. 2018 found that in 62.1% of reported transgender teenagers, they listed their health as being poor, fair, or good at best. In contrast to cis-identifying teens, comparatively, 67% of whom reported having very good or excellent health. Similarly, 25.2% of trans versus 15.2% of cis teens reported serious physical health issues, and 59.3% of trans versus 17.4% of cis reported serious mental health issues. These Ryder data also confirm that particularly in young people, the breakdown of transgender people's biological sex skews significantly toward female to male rather than male to female, with the Ryder sample comprising 80,000 9th and 11th graders who identified as trans, 68% of which were assigned female at birth versus 32% of which were assigned male at birth. It's important to note that while there isn't a ton of national level data on population trends in transgender people that delineates whether or not they are female to male or male to female, given that the entirety of the population of trans people again comprises less than 1% of the total populace, there is some, and it seems that this has been a relatively new alteration in demography. As research dating back to the 80s, as seen here in a review from Zucker and Lawrence 2009, indicates that a greater number of male to females versus female to male transgender people has been the historical norm. Further, in the summation of large studies conducted between the 1990s through the early 2000s, as collected here in this graph from Marciano 2017, generally found a greater prevalence for male to female transgender people in the past, with an analysis of data collected as recently as 2012 in the Dutch population in Cooper and Wilson 2013, between participants ages 15 and 70, there were still reported to be more male to female identifying individuals at 1.1% versus female to male participants at 0.08%. But since then, it seems to have flipped, as additional data from the United States, the United Kingdom, Canada, Finland, and other studies from Denmark have all found a rapid reversal, with more and more assigned female at birth people now identifying as transgender. This is particularly of import when it comes to children, because they have always been more likely to express gender identity issues, as data going back to 1974 illustrates, with an explosion of cases of young people expressing these kinds of concerns, gender nonconformity, going up, at least in terms of being referred to a clinic, and with adults now only approaching the same level of referral as children. Further reports from the UK, though, indicate that there's been up to a 4,000% increase in children presenting with gender dysphoria in 2017 compared to data from 1997. That's why this looks like an epidemic, because these changes in population are a big deal when we're talking about gender dysphoria affecting all of us potentially. And given this possibility for rapid onset, it means we could be looking at a plague. And I do mean a plague, given that there are some pretty significant outcomes here, including high rates of suicide, mental health issues, and physical health issues, as we've just covered. But to further illustrate how this is a growing problem, 2011 data from Gates placed the US transgender population at a 0.03% of the total populace. But with more recent analysis from just a half a decade later from Flores, Gary, Gates, and Brown, 2016, finding the number to have swelled to closer to 0.06% of the population. It doubled, and you might expect that California was topping the charts via the state-to-state analysis, but whoa lad, take a look at the district. We can see this trend visually represented here, though, from these data from Weirwick and Savelis, 2017, or here from Aitkins et al. It is seemingly undeniably on an upward trending slope. It's also worth noting that according to Flores, in the 18 to 24 range, 0.66% of people identified as trans, rather than 25 to 64 age ranges at 0.58 and 65 or older at 0.5. Herman et al. 2017 also found that people's age 13 to 24 were more likely to identify as transgender than older individuals, with a particular disparity in the 13 to 17 cohort, with 10% of all transgender people falling into that age range, despite said age range comprising only 8% of the total United States population. Younger people being affected is particularly of import here, as that is the group wherein the ROGD was initially identified. And going back to that data from Ryder and colleagues I mentioned earlier, they found across their survey of 9th and 11th graders that a total of 2.7 of their total population and sample of 80,000 participants identified as gender non-conforming. That 2.7 is over 4 times more prevalent of gender non-conforming or transgender identity than even the most recent national assessments of the prevalence of transgenderism across the general populace over the age of 18. Moreover, we can note that there were more 9th graders who identified as gender non-conforming or transgender than there were 11th graders who did. It seems that this tends to target younger and younger people. Again, doesn't mean you're still not at risk, viewer, but merely that we could throw age in as another potential variable that has something to do with your likelihood of developing ROGD. So it seems that we are looking at an epidemic, something that is growing in size. And while you might be as at risk as other post-pubescent youths described in the Littman study, it seems that gender dysphoria, particularly this rapid onset type, is particularly on the rise in young people. So be sure to use this guide not only to diagnose yourself, dear friends, but also your children or any young people that you may happen to come across on the street as well. Yes, that's right. Just walk up to them, shove your cell phone in their face and say, "Watch this!" That'll surely help. And while you're being dragged away by the police, listen to the rest of the video, which is related to why this matters and what can we do about it. Let's first take a look at some of the specific risk factors and how they may interact with both diagnosis and responses to those diagnoses. Beginning with this newer propensity of natal females, in contrast to natal males as it has been in the past, towards rapid onset gender dysphoria and transgenderism in general, particularly when it concerns young people under the age of 18 in these datasets, as we have seen. Going back to the Ryder data, in addition to being more likely to experience gender dysphoria and identify as trans according to current statistical information, natal females with dysphoria were more likely to experience long-term mental health problems. 68% of natal females who felt very masculine reported poor, fair, or good health, compared to 49.2% of natal males who felt very feminine. And further, 34% of natal females who felt very masculine reported physical health problems or disabilities, compared to only 19.1% of natal males. So we have some indication here that natal females might be at a little bit of greater risk or suffer a little bit more from this. So what then can we do to help these people? Well, typically anymore, it seems that treatment begins as soon as possible with hormone blockers to prevent the occurrence and onset of puberty. According to Dr. Littman's data, 36.2% of parents took their children to see a therapist after they reported feeling gender dysphoric. Luckily, these therapists didn't waste any time, with of those parents who did seek medical or psychiatric counsel reporting that in 71.6% of cases, the professionals considered no other mental health options other than gender dysphoria as a possible rationale for the child being brought in. And with 70% further reporting that no medical records were even requested by this council. Another full 23.8% of respondents who did take their children to see a therapist noted that the practitioner offered the child hormone blockers upon the first visit. I mean, that's great, right? We're getting these kids treated immediately with little to no medical evidence. Now, if you're a bigoted, conservative, literal Hitler like the big orange man who is really bad, you might think that this sounds radically irresponsible, considering that hormone blockers used to prevent the onset of puberty, followed by hormone therapy, result in sterility in many, if not most cases, for both trans men and trans women. But, silly conservative, you're being transphobic. However, I guess we do need to look at the bigoted transphobic data to see if that claim has any merit. It turns out that outside of hormones preventing typical reproductive function, we actually still know very little about the long-term effects of hormone blockers in conjunction with hormone replacement in both biological males and females. Research from Patch et al. 1991 found that an introduction of androgens to biological females presents very similarly, although not identically, to polycystic ovarian syndrome, or PCOS, which is a leading cause of female sterility. And although Ikeda et al. 2012 found that these effects were distinct and unique from PCOS, they also noted numerous changes in the ovaries that began after exposure to testosterone in comparison to their control group. In other words, yes, taking hormones has an effect on your reproductive organs. But I should note that things aren't completely bleak, as a study from Light et al. 2014 found of 41 trans men who became pregnant, 25 of whom became pregnant after having previously used testosterone hormones. But I want to point out a couple issues of concerns there with that study. First, the researchers did not ask, or at least did not report on if hormone blockers had been used during childhood before the administration of testosterone. Secondly, the majority, 64%, who had taken testosterone had only been taking hormones for 2 years or less. And while 68% specifically stopped taking hormones for the purpose of conception, these data are in no way delineated, meaning that the researchers did not report on the length of time before ceasing treatment of hormone therapy and the induction of pregnancy. The only thing that they did report on was on the average number of months after the cessation of hormones before menses returned. I know I was still kind of doing a bit there, and I sort of dropped it to get more into the data stuff, because you know that's my thing.
Anyway, what about the data? You do still have it, right?
Yep, got it.
But it's important to note how data can be very misleading and why we need a very careful read here, because if someone just looked at the abstract of the study, they wouldn't get that nuance. So sorry I dropped my act, I'm probably gonna just drop it for the rest of this. Actually, do you guys mind if I just drop the act? Let's just get into the real shit here. You don't have gender dysphoria unless you really have gender dysphoria. Do you think that you're not the gender you were born as? Sincerely, have you felt that way your whole life? Then you probably do. But if you're 16 and all of your friends suddenly became trans, probably not. Or at least give it a couple of years, right? We're gonna get into that now.
Just because little kids say something doesn't necessarily mean that you accept it or that it's true, or that it's in the best interests of a child.
Anyway, the point is that it's true that people who are trans and take hormones can still be fecund. After all, there is research that has indicated that teenagers who have been placed on puberty blockers often return to normal menstrual function or seminal fluid production after the cessation of these GnRH analogs. As noted here in Hembry et al. 2017's massive overview of research and guides for medical practitioners. But the fact is, you'd be kind of hard-pressed to find any scientist or any research out there that shows you the conjunction of hormone blockers plus subsequent hormone therapy. They all just kind of admit without actually admitting that it causes sterility. But the point is, if you're just on hormone blockers, you can always stop them, right? You can prevent this from becoming a long-term medical issue. Right? Except, according to Dr. Joanna Olson-Kennedy, one of the leading scholars in the study of gender identity in children, and someone who we will be talking about a bit here very soon, as she's quite an important figure, considering that she and her cohort recently received a $5.7 million grant from the NIH to study the impact of hormone blockers and hormone replacement therapy on children in 2015. Yet, Dr. Olson-Kennedy, in a now deleted interview that's still available on the Wayback Machine because I ain't letting you do that, and because the internet never forgets, admits that she only knows of one incident where a child was placed on GnRH agonists and did not then go on to receive hormone replacement therapy and ultimately sex reassignment surgery. And that's something Hambry and his colleagues admit there is really no data on, only suggesting that medical professionals inform patients that preventing puberty and then beginning opposing sex hormone usage may have a permanent result of sterility, and certainly so in those who proceed to have their sex organs removed or permanently altered.
You don't want to, for example, recommend surgery for anybody where you are worried that they're going to regret it, because surgery is irreversible.
And the fact is, we're talking about children. They're kids. They haven't even begun to think about their own lives, let alone having kids of their own. What the hell? And by the way, this isn't just me talking out of my arse. This has been confirmed by data coming from Dr. Olson Kennedy's own NIH grant funding, as published by Nahata et al. 2017. They found that despite 98.6% of their sample of 73 adolescent transgender youths between the ages of 9 and 18, only 2 of them, that is less than 3%, reported even attempting fertility preservation. That means they were told, you will most likely be sterile. Would you like to preserve your sperm or eggs? And only 2 out of 73 said maybe. Now compare that to this. Only 22% of that same sample said that they didn't want to have children. A little over 40 said they'd like to adopt, but I just like to let that sit with you. And by the way, 92.3% of this same sample presented with another serious mental health disorder outside of gender dysphoria, just as a note. But let's really look at the question here. You are asking a bunch of children with a mean age of 15 to make lifelong decisions about their fecundity. I can only speak for myself here, and my friends, I guess, but when I was 15, having a family was pretty much as far and incomprehensibly removed from my immediate future as I could possibly imagine. And that was for me and my friends, a bunch of 15-year-olds who were actually undergoing puberty, not young people who had had our natural pubescent development artificially halted. But Aiden, doesn't it help these kids? Sure, they may end up infertile, but with those suicide rates that you brought up, isn't it the right of therapists to fast-track kids as young as 6 or 9 onto puberty blockers and subsequently hormone replacement and then surgical options to ameliorate the danger of them becoming suicidal and taking their own lives? I mean, Dr. Olson Kennedy and colleagues in a 2018 study on young adults and children with gender dysphoric natal females aged 13 to 25 who had either undergone double mastectomy, 97% of whom had been on testosterone, or who were pre-surgery for mastectomy, 87% of whom were on testosterone, found that all of their post-mastectomy patients thought that having a mastectomy, that is having their breast tissue removed, was a good choice, with only 1 participant reporting any form of regret, which Dr. Olson Kennedy reported in her abstract as, quote, near 0. And you know what? That's true. In the study, that amounts to slightly over 1%. But let's look at how the good Dr. Olson Kennedy conducted the study. Did she ask participants to fill out an anonymous survey either online or on a piece of paper? No, of course she didn't. She and her research team conducted this through phone interviews. And I'm sure, considering that Dr. Olson Kennedy's research at every turn seems to be in conflict with that of her colleagues in her field of study, that being gender identity, this was totally random. There's no reason why they would have done this, right? And by being at odds with all of her colleagues' research, I mean even in people who try very hard to confirm her data, such as this study from DeVries et al. 2011, in which the abstract would seem to confirm that there are no comorbidity issues with other psychiatric disorders and gender identity disorder. Ultimately, when you go in and look at the data, you can find that yes, there are, with 32% of those who present with gender dysphoria having one or more DSM-4 diagnoses, compared to a 17% in the general adolescent population. Yeah. Even people who support Dr. Olson Kennedy can't seem to really get around some of the facts that gender dysphoria is a psychiatric disorder.
The suicidality can be related to the fact that these kids also have other mental health problems, so it could simply be part of that. It could also be related to family vulnerability to mental health issues.
And although Dr. Olson Kennedy found in her initial report, based on her NIH funding and her longitudinal research, that gender non-conforming children were no more depressed or anxious than their peers, that also flies in the face of all available information that we've looked at so far and is in direct conflict with decades of longitudinal and experimental research. But hang on, I've gotten off track. What is the problem with conducting phone interviews, particularly when it concerns a sensitive topic like transgender identity, and whether or not one is happy with having received a serious surgery such as a mastectomy? The fact of the matter is that any kind of face-to-face or phone interview has a greater potential to lead the participant towards the desired outcome or result of the interviewer. That's just kind of how leading questions work.
Size 3. Yes. It's just we've lost a dear one, and my son was... yes, that's right, size 8, yes. And... oh, I see. Yes. 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 Yes, yes. Yes. Yes, I see. Yes. Yes,
Even if you are a very well-trained person, the more human elements you add in, the more error you add as well. Are you sure you really felt dissatisfied with your chest surgery? Really? Are you super sure? Can you confirm that for me? Look, I don't know what actually happened here, but I can just see how that would be a very easy thing to fall into when you specifically use phone surveys rather than online or paper ones with the exact same Likert type instrument. It's something called acquiescence bias. I'm not saying that is necessarily what happened here, but it's why interviews are really only used in social science context, where those interviews might provide unique information, where the researcher becomes well-known or involved with the patient, and that might be the case here. However, when I looked at their data and I looked at the kind of things that they were asking the participants, it was a traditional 1 through 5 agree to disagree style Likert instrument. Here's the point. When you call someone up on the phone and administer them a Likert type instrument that you could very easily have done in a much more anonymous fashion via a printout that can be conducted in person or via an online test, you have purposefully added error where there was no reason to do so, except because you knew that if you bullied people on the phone, they wouldn't tell you the truth. That's it. That's the only reason you did that, and there's no other reason to conduct this as a phone interview, and really, you should be ashamed of yourself.
All right, that's it. Dishonor. Dishonor on your whole family. Make a note of this. Dishonor on you. Dishonor on your cow.
Another thing to really keep in mind here with that mastectomy research is that she used a very, very strong cutoff of 25 years old, with 64% of her post-surgical sampling having been 18 or younger when their top surgery was performed, with an average age of 19. And that's another place where Dr. Olson Kennedy and her research conflicts with a wealth of extant data, including predominantly the work of someone who we will come to know as the devil, Dr. Kenneth Zucker, who is the guy who is still to this day, despite all of his demonization, writing the literal book, that being the DSM-5 on gender dysphoria, and who has worked clinically in the field of treating children with gender dysphoria, gender identity disorder, and gender non-conforming issues for 30 years. But let's go over what Dr. Zucker, his cohorts, and other prior research has gleaned on this topic. Green, 1987, found in a longitudinal analysis of 44 boys who presented with gender nonconforming expressions in behaviors between the ages of 4 and 12, found that only one of his sample continued to present with gender dysphoria by the age of 18. Zucker and Bradley, 1995, replicated much of this initial study with an analysis of 40 gender nonconforming boys ages 3 to 12, and found that by the second assessment of their longitudinal analysis with a mean age of 16, only 20% of their sample reported still presenting with gender dysphoria. Cohen-Katenis, 2001, in another longitudinal analysis of 56 male children, found that only 16% persistently presented with gender dysphoria upon reaching adolescence. In biological females, in contrast, who again until recently had been a minority of transgender people, Drummond et al. 2008 found that of 25 girls presenting with gender non-conforming behaviors with a mean age of 8 in their initial assessment, in a follow-up where their mean age was 23, only 3, that is 12% of their sample, continued to express feelings of gender dysphoria. It seems that young children or adolescents often are just a bit flowy and fluid, if you want to use that term, of their gender expressions.
Some of the boys who desisted were just as severe in their gender dysphoria, in their cross-gendered behavior, as some of the boys who persisted.
Little kids can present with extreme gender dysphoria, but that doesn't mean they're all gonna grow up to continue to have gender dysphoria. Some will, but a lot won't.
It's not so much about them being confused of their gender identity, but rather that they are discovering through experimentation who they are. And to limit this by permanently changing someone's physiognomy through the induction of puberty blockers and sterility induction, that's not going to help.
We don't want mental health assistance. Yes, we do want to get together with other families like ours, but we don't want to see the psychologist. We don't want to see the psychiatrist. Our kid's just fine, thank you. If they say they're transgender, chances are they are.
In contrast, we see that studies concerning slightly older adolescents, as Cohen-Katenis and Van Goosen 1997 found that when participants were assessed at a mean age of 17.5, with a mean follow-up age 2.5 years later, a full 66% went on to receive sexual reassignment surgery, and found that no participants, though, of that group regretted undergoing their transition, and generally were more positive about their body image over time. They also had more positive mental health outcomes and psychological functioning. Of course, they are still only assessing relatively young people, but we're starting to see that there is kind of a greater propensity or persistency of emotion towards one's gender identity over time, at least in these older adolescents, compared to these younger adolescents or outright children. Further, Smith, Van Goosen, and Cohen-Katenis 2001 found that of transgender adolescents with an average age of 16.6 who had begun undergoing sex reassignment when reassessed at a mean age of 21 years old, they reported lower levels of gender dysphoria than people who were diagnosed at the same age of around 16, but at that second assessment had not undergone sex reassignment surgery, or hormone therapy, or anything similar. So, there you go, right? It seems that everything's hunky-dory, if in the words of the Dresden Dolls.
We need to chop your cock up, tick-tock, 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 tick-tock. It might not be what you expected. There is no money back once you've been ripped off, ripped off, ripped off.
When we start looking at the long-term health outcomes, they're not so fine. And I'm sorry, this is going to be a very long video, guys. As I mentioned before, there's a problem in all of these studies with participants potentially wanting to either acquiesce to researcher bias, or as a function of something called social desirability bias, which is not wanting to paint the transgender community poorly because you're part of it. So you want everyone to look positive. You want transgenderism, gender dysphoria, to be recognized as a real mental health issue, and I agree, it is. So of course you don't want to say, well, no, I regretted my transition, because then you look like you're betraying your fellow trans people. Despite the fact that you may very well know people in your own life and in your own community who have regretted their transition. But that's precisely why we need to look away specifically from self-reports, because self-report can be highly subject to the kind of contamination I just mentioned, and into actual outcomes. and the actual outcomes, they're not positive, guys. Looking back at the Haas data, we can see that across pretty much all categories and treatments, propensity to attempt suicide was identical or nearly identical in transgender people who wished to receive a certain treatment and those who had actually received it, across any number of options, including hormones, forwarding a decrease in suicide propensity by 5%, that's the highest, mastectomy patients by 1%, and hysterectomy by 1%. Both male to female and female to male bottom surgeries resulted in no change in suicide attempts, and receiving counseling even increased suicide attempts from 39 to 44%. The only consistent positive effect was in female to male phalloplasty, indicating reduced suicide proclivity from 56 to 46%. But I mean, that's obvious because everyone wants a dong to spin around like a helicopter, right? It doesn't seem as if sex reassignment and hormone treatment impacts long-term outcomes, though. As Dene, code talker, am I saying that right?
Yes. I became obsessed with them. I wanted exposure to them. I was seduced by the beef.
Et al. 2011 found, indicating in their longitudinal analysis data of the Swedish population that after undergoing surgery or hormone treatment for gender dysphoria, both male and female transgender people were significantly more likely than the general population to commit suicide. So we don't just have correlates here, we actually have a longitudinal effect. It means that having surgery and taking hormones does not generally decrease your propensity to commit suicide. So why are we doing this? In terms of the actual output, we find absolutely no improvement in suicide attempts or in suicide completion in those who had undergone treatments prescribed to children ages 9 and over, with diagnoses now being given to people as transgender potentially as young as 3 in the West. We are giving hormones or puberty blockers to very, very young children, despite the fact that we know nothing about the long-term effects of these drugs on children. And despite the fact that we know they don't have any positive outcomes, not that we can find long-term. And that's the quick and dirty here. We give people who suffer from these disorders drugs and surgeries that don't appear to be working. And more harrowingly, the researchers who are encouraging this don't appear to care. You think I'm lying? Let's take a look at the horse's mouth. As one of the leading gender scholars in the entire field, Dr. Rensaft, so eloquently said here in a talk, do the parents of cancer patients care if their children are fecund? Well, surely only the horrible ones.
The question is, can an 11-year-old, 12-year-old at that level of development be really thinking and know what they want at age 30 around their fertility? So the answer to that is, we don't stop twice about instituting treatments for cancers for children that will compromise their fertility.
But one of these things just doesn't belong here.
We don't say we're not going to give them the treatment for cancer because it's going to compromise their fertility. That for some of the youth, having the gender affirmation interventions are as life-saving as the oncology services.
I don't believe you.
Her colleague then goes on to further emphasize the point mentioned in Dr. Littman's data now so long ago. What would you rather have? A mutilated child or a dead one? You better tell your parent or your health provider you're gonna kill yourself to get some hormone therapy in order to make them feel bad.
Just make sure you have all the information as you make that decision, which includes you can either have grandchildren or not have a kid anymore, either because they've ended the relationship with you, or in some cases because they've chosen a more dangerous path.
Damn, that fucked up.
So that you can get what you want without having to think about it. Because don't think about it, remember? Don't think about that either. They specifically said, don't think about it. You'll regret it if you think about it. All of this, without a lick of data that sex reassignment surgery, that GnRH, hormone puberty blockers, and hormone replacement has any impact on suicide rates of young adults and adults who report as being transgender with gender dysphoria. Do you know who has reported some positive results? Why, it's Dr. Zucker's cohort, whose clinic was shut down in 2015 in Toronto, Canada.
If somebody as prominent as Ken Zucker could lose his job for being reluctant to join the trans bandwagon, what could happen to me if I expressed any reservations?
Which, of course, Dr. Arnsoft in that same panel lauded, because she just doesn't like his model.
For those of you who don't know, in December 2015, this clinic was closed for being practicing below the standards of care. That's the model. Okay, we don't like that model.
Well, what is his model? It's encouraging children to love the skin they're in. What a bigot. As Zucker notes in a 2009 review of his research, for example, regarding a young male child who reported wanting to be a girl, quote, "Once she, the mother, began to verbalize to Sean, the child, that she wanted him to feel happier about being a boy, he rather easily stopped cross-dressing in her clothes, stopped playing with Barbie dolls, and with parental support began developing close friendships with other boys." Previously, by the way, that child had struggled developing friendships with boys and his father. This obviously runs contrary to the desires of many of the researchers who suggest that these children should, rather than try to fix their mental state or ameliorate their mental state to be happy with the skin that you're in, should alter the chemical composition of your body and mutilate your genitals rather than trying to love yourself for who you are. I'm not saying there aren't people who are transgender. Don't get me wrong. I should have made that obvious at this point, but people will always take me out of context. The fact of the matter is, yes, there are people who will feel like they're the other gender. But does that mean that the best choice is to permanently mutilate and alter their bodies? I just am not seeing the evidence, and you don't have the evidence because there is none. You can't provide me with the longitudinal data I'm asking for because it doesn't exist, and that's the issue. That's why they want to shut people like me up. That's why they want to say anyone who even brings up critiques is a transphobe. They can't have an opinion. Their clinic needs to be shut down. Their research needs to be stifled. Why do they do that? Because they don't want transgender youths to actually get help. They want them to hurt themselves and be at the exact same risk of suicide as they were before they mutilated their bodies. And we'll get into that. My point, though, is that I am obviously not claiming that transgender people don't exist. In fact, we find from some hereditary information that, yes, transgenderism is related to heredity, with Halens et al. 2012 illustrating that 39% of monozygotic twins concordantly reported gender dysphoria across both twins, with no relationship, in contrast, reported between propensity for gender dysphoria or gender identity disorder across dizygotic twins of the same or of opposite sexes. In other words, yes, we see that there is a hereditary basis for feeling gender dysphoria. It is not made up, it is not fake. It is a real thing people experience based on brain chemistry as far as I can tell. That doesn't mean we should go chopping off people's healthy sexual organs to treat it when we find absolutely no evidence that that helps. In fact, what is probably more likely is that with many of these young people, you're just looking at homosexual children who are discovering their identity. And I'm not pulling that out of my butt. There's a lot of data on it, including Zucker, Green, and Katenis. I guess they're naughty people, but they found that many children in their analysis, about 60 to 80%, who were initially reported as gender non-conforming or having gender identity issues, ended up, as adults, identifying as homosexual. And considering that homosexuality also seems to be hereditary, this is all kind of making sense. Yes, you might be gay. Yes, you might be trans. But it seems to me that we're prescribing transgenderism to a lot of potentially just homosexual children, and the problem is that being gay doesn't involve chopping your dick off. I mean, not usually. But considering that overlap between transgenderism and homosexuality, we can't even really effectively delineate transgender status from homosexuality in either sex all the time. And then in response to the vague notion, we seem to prescribe medications, the long effects of which we admittedly don't have any information about. And the person to whom we have just given a nearly $6 million grant in the United States to study all of this has herself a pretty both implicit and explicit bias that she's presented both in her speeches and in publications to push forward just treating people that she thinks are transgender from a very early age before waiting to see if they're actually just homosexual, before waiting to see if they're just experimenting with gender identity. No, 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 don't allow them to progress. Just prescribe and move on. That is bad medicine. But I'm not allowed to criticize her. No, of course I'm not allowed to criticize Dr. Olson Kennedy, because that makes me a bigot. And that's how they all respond to this, as you've probably seen. If you dare say, hey, maybe you should do some clinical trials before you put children through this stuff, you know, the things that we would do for any other medication, how dare you, you bigot, you transphobe. Just as with Dr. Littman's data, indicating that anyone who criticized the children who came out as rapidly gender dysphoric as transphobic and bigoted and evil. It's all coming together now, in it. I've obviously at this point dropped my whole act about trying to diagnose you with rapid onset gender dysphoria like a hot sack of beans, and as such, I have to get more into the viciousness of this whole Ponzi scheme. And that concerns the comorbidity of not just femaleness, as I've described, but also autism and other neurodivergent disorders with gender dysphoria, including in today's focus, the rapid onset gender dysphoria and why it matters. Dr. Sally Powys describes their relationship thusly.
The research that is out there all seems to show that there's an increased prevalence amongst people on the spectrum, anything from kind of 5%, 8%, a very recent one last year up to kind of 23%. My gut instinct, which is just my personal opinion, is that that's probably correct. I think because of the issues I've been saying, because of the gender fluidity, because perhaps people on the spectrum as children might be less cued into social norms, that kind of thing, I think there probably is.
Some of the most recent findings from Halens et al. 2018 have found a particularly strong correlation between the findings that we saw in the Littman data, indicating that a full 6% of participants within their study who had autism spectrum disorder or an autism spectrum diagnosis also presenting with gender dysphoria. This matters for the exact reasons that Dr. Powys provides, despite her potentially much more positive spin, describing that people with autism by definition often struggle with fully understanding these social situations and nuances in which they find themselves. Thus, they are often likely to also struggle with understanding gender roles among other types of social interactions. And more nefariously, as this could be misconstrued or misused by people with a political agenda, they can be potentially fairly easily manipulated into conforming to any kind of social behavior that is encouraged, either through bullying or through social stigmatization or through social pressure, more so maybe than the average person who doesn't suffer from autism disorder or autism spectrum disorder. But speaking of bullying, remember when we go back to that Littman data, that a lot of the people who came out as transgender in that rapid onset nature felt that their friends were bullying those or were mocking those who were not trans, as well as a considerable number of them being autistic or having autism spectrum disorder or other types of neurodivergency. That indicates to me that there's a little bit of a little bit of a quandary here. But don't just take it from me, there's further information to back that up, albeit anonymous. As a tip from a UK teacher to the Daily Mail, and the Daily Mail is a rag, so take it as you will, noted that 17 students at her school were currently transitioning. And while the whistleblower asked only to be identified by the name Carol, she said she witnessed a 16-year-old natal female who had been recently diagnosed with autism also begin to shortly thereby identify as having gender dysphoria and being transgender in 2016. Shortly after identifying as transgender, other students within the school who were also autistic or who were quickly diagnosed as autistic, at least according to Carol, similarly were pressured by this initial student or by their peers to also identify as coming out as transgender or gender non-conforming. Again, this makes sense for autistic people who often struggle with social interaction, making them particularly vulnerable to this kind of social manipulation. This is likely a similar struggle for those who suffer from ADD or ADHD, which according to the research research we've already seen, but also further from Strang et al. 2014, is highly comorbid with gender identity disorder at the level of 4.8%, second only to autism, which in Strang's data was related at 5.4%, compared to no incidences of either disorder within the general public in the gender-conforming control group. Given I've explained the hereditary information related to being transgender, I'm obviously not saying that people cannot be transgender or are not transgender, or that people do not legitimately experience gender dysphoria. I'm actually kind of saying the opposite of that. I think that people do suffer from that problem, and what I find disconcerting is the fact that we're not treating it. Instead, we are fast-tracking young people to take hormones and to transition, when in reality we find that a lot of this tends to stabilize over time, or that many of these young people end up being homosexual rather than transgender. Not to imply that transgender does not exist.
Trans activists don't like the high rate of desistance talked about, because if you know that 80% of gender dysphoric children are going to end up as ordinary gay men, I'm going to encourage all of them to try and adapt to their anatomic sex, and the handful that are destined to be transsexuals no matter what will sort themselves out later.
What I'm really describing here is that it's probable that gender dysphoria, what I've been describing, is actually more likely a form of social contagion more than it is a mental disorder when it comes to things specifically like the rapid onset gender dysphoria described in Littman's research. Hence why otherwise normal people, quote-unquote normal, would seemingly be at risk for such an extreme disconnect between the physical body and the mental sense of the self. That is, when everyone else in one social circle adopts a certain behavior, you and I are both very likely to adopt and adapt that behavior as well. I'm not trying to be insensitive there, I'm just being contextual. And by that I mean, there's no reason to believe that transgender and gender dysphoria somehow exists in some kind of bubble outside of other mental health problems. And numerous other mental health issues have been identified as being potentially socially contagious, particularly so in highly mutable and influential adolescents, including suicide epidemics and plague-like spreading of eating disorders across teen social groups. When Marilyn Monroe was reported to have killed herself in 1962, it became a fairly now well-cited study that suicides leaped that year, pun intended, by 12%. And while we have seen a significant amount of evidence over the years for the existence of what's called suicide contagion, I mean, hell, the comedic genius M. Night Shyamalama Ding Dong made an entire film on the topic, but with pollen instead of society.
Experience the first movie since Groundhog Day to make suicide look kinda hilarious, as trees begin to emit a toxin that makes us kill ourselves in the most convoluted ways possible. In this non-mystery, non-thriller that spoils itself in the first act. It's the plants.
But there is some potentially more relevant information we can look at here in Foreman, Hoffman, and Cunningham's 2008 research on eating disorder contagion. They found that possessing any type of maladaptive eating disorder tended to cluster by locale via county, particularly in the cases of female students who adopted eating disorders. They noted that this effect was particularly prevalent in younger teenagers. And what does that mean? It means that teenagers and adolescents are sometimes easily influenced by their friends, their environment, and their social networks as they attempt to appear normal. That's kind of a no-brainer, right? And as a Littman study on ROGD noted that we began with, if the new norm is being transgender or gender non-conforming, then guess what? You're going to get a lot of confused kids who quickly sort themselves out as being transgender or gender non-conforming only because that's what's in vogue. And as they grow older, they either grow out of it, as many of the participants in the Littman study did, and in fact an interesting thing to note there is that the children who had been transgender or gender nonconforming identified for the longest were the ones who were most likely to detransition or to step away or walk away from it, at least according to these basic correlational level data. But the fact of the matter is that when you start to introduce these very confusing factors, you're going to get a lot of confused kids who don't quite know where they fit in. They just know they want to fit in with their friend group, and if their friend group is all trans, well, guess what? You see not only an increase in transgender people, particularly across the adolescent and youth population, as we have seen, but you also get a lot of people and a lot of children, which is the most harrowing fact, who end up on hormone replacement therapy, puberty blockers, and ultimately sexual reassignment surgery, despite the fact that really they never thought about it themselves. They went to a therapist, or they talked to their friends, or they went online and they were given this diagnosis, and just because they wanted to fit in because they're 16, 17, 18, they went along with it. And that's really the terrifying thing. That is really the reason and the rationale behind this existence of rapid onset gender dysphoria. And why is it such a great increase? Well, it's because at one point I think, and tell me if you think I'm wrong, I've got some data here, but hang on. I think that at one point, even based on a lot of gender theory that we've had for years now, since Bem's research in the 1970s, that we've become more and more accepting of people with non-stereotypical gender expression. That we've become more okay with people not fitting into small gender boxes. I think that was never really a major issue, but potentially it was. So let's look at that. Is all of this just a new stringency defining people as male or female and thereby transgender or not transgender based on whether or not they fulfill certain criteria of gender expression? Well, Cohen-Katenis et al. 2003 found that in both Toronto and in the Netherlands, boys with gender identity disorder had significantly poorer relationships than did girls with GID. That was consistent with normative studies that showed across gendered behavior that boys are subject to more negative social pressures than cross-gendered behaviors in girls. This is important because, again, we're seeing this rise in people that we previously had never seen. It's because up until now, it seemingly was okay to be a girl who liked boy things.
Let's see if we can teach this girl that there are a lot of ways to be a girl. Some girls like Barbies and some do not. Some girls like dresses and some do not. Both are equally acceptable.
Although I will admit, it has not always been okay to be a boy who likes girl things. What I'm saying though is that the acceptance of tom girls as normative for women is not a new concept, as data going back as far as Green, Williams, and Goodman 1982 find that female tomboys were likely to have many positive same-sex group relationships with their peers of the same sex, in comparison to feminine boys who were less likely to be socially accepted and more likely to be rejected. I remember this myself in my own personal experiences, again anecdotally, growing up in the mid-90s. No one ever rebuked me for being interested in more typically masculine things, if not the sport ball, something I still to this day don't understand. Again anecdotally, my dad used to tell this story all the time about on Christmas Day in 1996. I'm 6 years old. I opened all of my presents and I went into the computer room in order to install my latest computer game. That's already kind of a sign that I'm not the most feminine, at least according to 1996 standards, right? And I came back out and complained to him that our computer didn't have enough RAM to run Madeline's European Adventures. Again, starting to get a little gender confused if you think only girls can like Madeline, and only male-identified people can enjoy computer parts. But the fact of the matter is my dad went out and we purchased a new computer that could run the blazingly fast and new technology of Windows 1995, a computer upon which I proceeded to play Civilization 2 with my dad over a very basic internet connection. The point is, at the time, in 1996, a 6-year-old girl saying anything about computers and RAM, that probably wasn't normative as female, but no one discouraged me from being that way. In fact, it was heavily encouraged, as I implied. I didn't start wearing dresses and wearing makeup until I was in my mid-teens because I felt no need or desire to. I was never discouraged in that way. My mother also was a tomboy when she was a child, and she has told me that she never felt ostracized for being that way. That was back in the 60s. And yes, those are anecdotes, but the data support our anecdotal evidence. That point being that for a long time, girls have had a bit of an easier position in terms of being, quote, gender non-conforming, which in and of itself itself, I should note here at the end, is an absurd term because it implies that gender expression can only contain certain aspects. You can only be this way if you're a girl, and you can only be this way if you're a boy, when we all know that that's just not correct. And while people like Dr. Onset will sit up on their podium and say, no, that's not how we think or conceive of gender, when it comes to their actual research and the things that they propose, that is obviously how they actually think about genders. They like to say that gender is a social construct, and by the way, I think that it is, in terms of behaviors. But these people, they ultimately believe that gender and sex are identical, in that if you act in any way that under the BEM sex role inventory does not conform to gender stereotyped behavior that matches up with your biological sex, then as a child, you're transgender. You are gender nonconforming, or you have gender identity disorder, or whatever you want to call it. That's how all of this has worked out and played out in terms of their research and in terms of what they will actually tell you when they have a little bit of a less scripted response. The fact of the matter is that, as I've shown, a lot of young children just tend to change. They're experimenting with the sense of the self. So if you're a young boy who just wants to be alone and feed your birds, it's not apparently possible that you're just, as I've discussed, likely to grow out of that, or maybe likely to be homosexual, or just likely to be experimenting and being different as a kid because your personality isn't solidified. No. According to these people, your gender identity is solidified from the moment you open your eyes. However, at the same time, there's no differences between male and female. It's a big clusterfuck. I really can't imagine how incredibly difficult it must be to wake up every day as an intersectional feminist and try to just work this stuff all out in your head. The problem is that we don't just take that boy who's a little bit flowy and more into feminine things and say, oh, okay, Johnny, you just express yourself. No, we take him, we put him on hormone blockers so he never goes through puberty, and then immediately start him on estrogen, and then immediately start him on sexual reassignment surgeries. He never has a chance to actually experience life normally. Now, I understand the caveat. I understand the criticism being, well, if we don't start these people very young, then they'll never look like the opposite gender. But I've seen some pretty good works at transitioning of people who were post-pubescent. And considering we still don't have any data that doing all of this surgery and engaging in all of this hormone therapy helps in any way of the major negative outcome that they themselves tell young people to use as leverage against their parents and doctors, that being suicide rates, there's no data there that shows that any of this helps, then what are we doing? You're mutilating people without any proper information.
It just so oversimplifies the data that you have to understand that narrative more as a political or a psychological argument than a reflection of science.
And moreover, as I mentioned, you're the ones conflating biological sex with gender expression. When you say a little boy playing with dolls means that he's transgender, who here is conflating those two concepts? It's not me. I'm saying maybe that little boy is a little gay, but maybe he's just expressing himself and he should be allowed to play with dolls. Maybe little girls should be allowed to play with tools without having their hormones blocked and their puberty suspended. How about that? It seems no longer can tomboys be tomboys. Now we're all transgender, and it's spreading like wildfire because of course it is. It's popular, and why is it popular? It's popular not only because of the mainstream media push for it, no. It's popular because, as parents in Littman's own study noted, it made their kids untouchable by bullies because the only thing that the teachers cared about was transgender bullying. In fact, it makes them so untouchable that Dr. Littman's own institution, Brown University, rescinded the blog post that they originally made about her study. And while the study is still available on PLOS ONE, that action represents a rather amusing case in point. Dr. Littman could not even be supported by her own academic institution merely because it triggered some trans people or trans activists. I'm sorry, but if your position is so weak, it can't take not only criticism, but actual data-driven criticism, then there's a reason why your position is so fragile, namely being that it is a house of cards. Further, the Brown Academy cited that the study needed to be meticulously critiqued because it needs to be meticulously critiqued. However, I would like to ask Brown University, how many other studies have you posted blog posts about and then asked that they be meticulously pulled apart by academics and non-academics alike? I'm guessing it's 0 others. I haven't really looked into it, but just guessing there's not a lot that you would have made this kind of statement regarding. I think that if it had been a study that fell in line with the research that is published by the likes of Drs. Olson Kennedy or Unsoft, you know, people who receive money and applause when they talk about their transgender research, you would have been okay with that. But the only reason that you chose to redact this publication or redact your announcement of the publication of information that potentially even questions some of the hypotheses of the aforementioned researchers, such as that from the likes of Dr. Littman or Dr. Zucker, yeah, you're fine with shutting that down and silencing that. And why would that be? Maybe because it fits a political agenda, I mean, why else? Why else? What other reason would you possibly have, as there is no weak evidence, let alone strong evidence, of any kind of positive long-term effects of using these puberty blockers or hormone replacements or of sexual reassignment surgery? There is just no data there. This is essentially what we are engaging in right here, an ongoing worldwide experiment being conducted using unwitting children without any available ethical information that would allow for this to be conducted on a more moral level, and with none of the same stringency that we would find or that we would give to any other kind of medical research. For some reason, this is absent of all medical stringency. What we are looking at here is the Tuskegee experiment on an international scale being conducted under the noses of thousands of parents who, if they dare even question the validity, are potentially at risk of losing their children. That's real. And as an academic, if you dare even question the data, as Zucker or Littman have, labels you as an academic pariah. These are children trying to discover themselves in their formative years of personality development. Let them experiment with that. If they do show overwhelming gender nonconforming traits, then maybe they're just gay, as Zucker and Lawrence 2009 noted in their review of the literature. Both trans men and women often tended to be exclusively homosexual, meaning they were sexually attracted, in their definition by the way, to people of the same biological sex. However, that was found to be particularly true in their review of trans men, being consistently more likely to be exclusively attracted to biological women. My major issue is that it feels that no one on the left who is pushing these political agendas seems to actually care about any of the kids or young adults involved in any of this, many of whom are, based on the wealth of information on psychiatric comorbidity with things like depression, anxiety, PTSD, ADD, ADHD, and autism, are highly at risk and are vulnerable. We're talking about an easily influenced, vulnerable population in general being adolescents, with any number of additional vulnerable aspects, be it homosexual preference or mental health concerns, being subject of a massive worldwide medical experiment that is being conducted ongoing with no control factors, no expectations for results. We're just giving medicine to kids and hoping it works out. And then, if someone even reports being dissatisfied, you better throw that data away. You better just ignore any research coming from the likes of Zucker and his cohort, who actually showed that they were able to help some kids through cognitive behavioral therapy to make them feel more comfortable in their own bodies without permanently physically altering that body. And that's the thing we need to make note of. These are real human bodies. These are real human children who are suffering under this right now. I know I like to put everything into numbers, and yes, you can quantify this, but we need to make clear these are real people who have to suffer the long-term outcomes of what we do to them. This is visceral, and more importantly, as I noted, the children who are being targeted here are often uniquely vulnerable children in and of themselves. In addition to the aforementioned issues, according to the hospital data, many transgender people who attempted suicide have also been emotionally and sexually abused. These are the people being encouraged socially, online, offline, and medically and educationally to identify as transgender because guess what? It gains social capital. It is socially lucrative to do so right now. And that's something that's potentially really impactful for individuals and children and adolescents who don't have a lot of other social capital, those who struggle with socialization. You know, a trait that defines many of the correlates I've just described, ADHD, autism, and so on. Rather than just waiting a bit to see if these kids are gay or going through a phase of self-discovery, no, let's just cut off their breasts or their penises, because that will, despite no evidence that it actually helps, clearly fix them. And there are real people who have regretted transitioning. As hard as it often is to find that information, because not only of the social desirability effect that I mentioned, but because many trans people have a level of cognitive dissonance about their past behaviors. They know that they went through transitioning and they don't want to think that they were wrong. None of us want to think that we were wrong in our past behaviors. So as I end here, I want to note a few specific caveats, and I'll show them to you, friends, but the terrifying reality of all of this new medical practice is that it's a treat first, ask questions later paradigm, and we can find that representative in the likes of someone like Cari Stella. Cari is a detransitioned woman who as a teenager was placed on testosterone and who underwent a double mastectomy, and she has spoken out repeatedly about the problems within the scientific community regarding transition, specifically regarding the scientific community's apprehension to even acknowledge that people like Cari exist. But let's let her explain some of it in her own words.
Gender means anyone who defies societal expectations regarding gender. What? So, my mom, who uses power tools and wears pants to church, is transgender. My brother, who used to have waist-length hair and would get mistaken for a girl all the time when he was little, he's transgender, I guess. God, I've got a buzz cut. I'm not wearing any makeup. I don't even remember the last time I shaved my legs. God, fuck. I need to stop making this video, guys. I'm sorry. I've got some calls I need to make to my endocrinologist.
In 2016, Cari conducted an informal survey through a blog of hers on trans men, with 203 detransitioned former trans men responding. So it's not clinical research and it's not peer-reviewed, but we've already seen how those in academia seem prone to use tools that strip anonymity for some reason, when it seems to give their own studies some more credibility towards the goal they're looking for. So the data are still worth noting, but with a substantial grain of salt. And her findings not only confirm a lot of what we've seen here, but also provide some potential additional relevant information. For example, trans men who had detransitioned back into identifying as women were significantly older in age on average than trans men who were still transitioning. While that's not surprising, it provides context into why people like Dr. Olson Kennedy don't want to interview or include data from trans men over the age of 25 in their research. Further, 67.8% of detransitioned trans men reported they had received inadequate information about transitioning before engaging in it. Most of those felt that detransitioning had a positive effect on their lives, with only 24.5% believing that their situations since ceasing or detransitioning were worse or unchanged. While in contrast, most participants reported feeling negative about their own transition and about transitioning in general. In the extended responses, many participants reported feeling pressured into transitioning and coming to accept their bodies into which they were born as being a healthier way of coping with their gender dysphoria and mental health issues. Something which I should note was also stated by some of the participants in the Light et al. Trans pregnancy study, with trans men who became pregnant noting that they felt happier with their bodies when said body was accomplishing its function. And as I said, this pressure to become trans, it's not just for the people who are actually being told to transition, it's for their parents as well. Right now, there are several cases that indicate that parents who don't believe their children, who are as young as 6, should be designated as transgender and begin hormone blockers, may potentially lose custody of those children because they're bigots. But that's why all of this matters. The people, the children, the adolescents, the individuals and their parents and their families who actually undergo this. We had to take it out of just the numbers, and I know that's hard for me. We have to take this away from just the data and look at the visceral individuals. That is why all of this matters. She is why all of this matters. This woman, Cari Stella, she's why it matters that we look at this. I'll let her explain again in her own words.
Understand that people like us are not just statistics. We're not just some dry data some gatekeeping doctor might throw at you. You know, we're real people. This is a real outcome of transition. I'm a real, live 22-year-old woman with a scarred chest and a broken voice and 5 o'clock shadow because I couldn't face the idea of growing up to be a woman. That's my reality.
So as I wrap this up here, this being very long, and I'll be displaying my amazing patrons as I go through this last note because this video has been long as hell and is still nowhere near a complete review of the relevant information. But it's worth noting that the study that kicked this all off, the Littman study, which was effectively silenced by Brown University, was conducted entirely using parental report rather than self-report or empirical observation of teenagers. And that's probably why a lot of people will get very angry at this video and why they got angry at the study from Dr. Littman. In research, you're always going to run into issues of methodology like this, but I just want to point out that asking parents about their children's behavior is, well, you've been a child at one point, haven't you? Likely not representative of the reality and the complexities of any individual adolescent's life. At the same time, adolescents aren't great at describing themselves outside of their awful poetry either, so really we're only left with meticulous empirical observation, which is very expensive and difficult. So regardless of that being a very major confound, I would say I've rarely found any other study being actively removed from a university website with the said institution then calling for the study to be pulled apart and criticized heavily. I've never seen that before. I think that's just important to note, as if anybody who actually cares about how reasonable and middle of the road I'm trying to be here, and usually am, would listen this far into this video. I'm just trying to point out the flaws of both sides. Just as, while I really enjoy the study that I've been citing here from the Jungian analyst Lisa Manciano, it just cites a few too many Guardian articles for me, seemingly aimlessly, to the point of even wondering how it got published, no offense. And as I most recently mentioned, Cari Stella's personal survey, which is not academically sound, although it does provide us with some interesting information. I have no reason to believe that she would be any more likely to manipulate her data than Dr. Olson Kennedy, who we know doesn't have a great sort of track record there. But for this video, I want to provide you with a reasonable critique that you could offer to the opposing side. And by the way, I started all of this thinking, oh hey, this will be a quick topic I can cover, and almost immediately delved into a deep research hole that I had no idea was this profound. The fact is, there's just way too much to cover in one video. We're already going way over my own typical video length, and we're not anywhere near discussing everything that I have in my catalog here. And that's kind of the point. There's just way too much that we don't know about all of this. We don't know how this medicine is going to impact a lot of these kids, and yet we're prescribing them with it anyway. We're blocking their puberty, we're prescribing them with hormones that sterilize them, and we are removing their genitals. And we have no evidence that it helps the problem we claim that it does. At least not based on any of the research that I've seen, and I've read research that both affirms and opposes the claims. In terms of longitudinal stuff, nah, I haven't seen anything that affirms this. So far, all we have are studies that only seem to want to make a political statement, not ones that are actually concerned with the lives and well-beings of these young people. But what do you think? Do you think that we should just go ahead and willy-nilly prescribe this stuff without any indication of what it might do long-term? Or is this actually just a political movement with very little to no concern for the individuals involved? After all, they don't seem very concerned with Cari Stella. But tell me, what do you think? And please, by the way, go check out Cari Stella's blog. It'll be linked below. Do you think that this is intentional or just bad science, or maybe good science is just not doing due diligence, or something else? Again, tell me in the comments. If you've enjoyed this video, please be sure to like and subscribe. I'm Aiden Paladin, Altana Volt.
It's an intellectual and clinical mistake to think that there is one single, quote, cause that explains all gender dysphoria.
Also, be sure to subscribe to PewDiePie. Be sure to do your part to help him win the war against T-Series.
And the only thing I can say about that is I'm Jewish.